Today we are going to discuss the prototypic ovulatory menstrual cycle in the reproductive age patient. We're first going to talk about the two parts of the normal menstrual cycle, the follicular and luteal phases, followed by a discussion of the hormones that are involved in these two phases, then the endometrial changes prominent in the two phases, and lastly, the physiological findings that help differentiate between the phases. Although an ovulatory menstrual cycle may range between 21 to 35 days, the mean cycle length is 29 days. A menstrual cycle is divided into two discrete phases. The first phase of the menstrual cycle is called the follicular phase and may be of variable lengths, sometimes shorter and sometimes longer than 14 days. The second phase is a luteal phase, the length of which is always 14 days plus or minus 2 days. For example, for a 32-day menstrual cycle, since the luteal phase is 14 days, the follicular phase is 18 days in length. The follicular phase starts at the beginning of a menstrual cycle and ends with ovulation. At the beginning of each menstrual cycle or follicular phase, a new batch, also called cohort, of follicles reaches the point of maturation that makes them gonadotropin sensitive. Each follicle contains an oocyte. By day 5 of the menstrual cycle, one of the follicles is usually selected to be the dominant follicle that will continue to mature and then ovulate. The other follicles that aren't selected to be the dominant follicle will undergo atresia and die off. After ovulation, the residual or dominant follicle becomes the corpus luteum. This is the phase called the luteal phase and lasts until the end of the menstrual cycle. In addition to producing estrogen, the corpus luteum now importantly produces progesterone. If the corpus luteum is not exposed to HCG of a pregnancy by day 9 of the luteal phase, it will begin its demise with a drop off in the estrogen and the progesterone secretion. In the absence of pregnancy, the corpus luteum and the luteal phase will last a maximum of 14 days. Now let's talk about the hormones involved in these two phases. A normal ovulatory cycle is regulated by simple feedback mechanisms between sex steroids produced from the ovary and pituitary gonadotropin secretion, some of which is mediated through the hypothalamus. As estrogen levels nadir with the demise of the corpus luteum, the negative feedback relationship between estrogen and FSH comes into play. As a result of low estrogen levels, FSH levels begin to rise and stimulate estrogen production from the cohort of follicles. As the dominant follicle is selected and produces increasing amounts of estrogen, negative feedback comes into play, and the FSH levels begin to drop. It is the competition for the decreasing amount of locally available FSH that allows the dominant follicle with more FSH receptors to emerge from the pack, and the smaller follicles that are robbed of FSH die away. As estrogen levels peak at the end of the follicular phase, at approximately 250 picograms per mil, a new positive feedback mechanism comes into play. The higher estrogen levels are followed in approximately 12 hours by an exaggerated secretion of LH, called the LH surge. FSH levels also peak at the same time, but to a much lesser degree. Follicular rupture and ovulation occurs 40 hours from the onset of the LH surge.
Let's now examine the changes of the endometrium that occur over the two phases of the menstrual cycle under the influence of the sex steroids. Estrogen stimulates the production of both estrogen and progesterone receptors on the endometrium. When estrogen sits on its receptors, the effect is one of endometrial growth or proliferation. Exposing the endometrium to estrogen is like watering a field of grass. As long as the endometrium only sees estrogen, it will continue to proliferate. The follicular phase can also be referred to as the proliferative phase of the menstrual cycle. Progesterone is the dominant hormone for its influence on the endometrium during the luteal phase of the menstrual cycle. It limits both the numbers of estrogen and progesterone receptors on the endometrium. As a result of decreasing estrogen receptors, as soon as progesterone is produced, there is a halt to endometrial growth. In a sense, progesterone acts as a compactor of the endometrium. When progesterone sits on its receptors, endometrial cells undergo a change called decidualization, and the endometrial glands begin to produce secretions, both of which are necessary for implantation. The luteal phase, thus, is also called the secretory phase of the menstrual cycle. In the absence of pregnancy and the decline of sex steroids, especially progesterone, a sequence of events at the level of the endometrium occurs that includes the production of prostaglandins and arteriolar spasm and results in a uniform shedding of the endometrium. This is the end of the menstrual cycle, commonly known as the menstrual period. Taking a brief menstrual history will quickly reveal whether the patient is having ovulatory cycles. First, regular cycles with lengths between 21 and 35 days are almost always ovulatory. Remember to count now from day 1 of one menstrual cycle to day 1 of the next. An astute detective will gather a bit more information about symptoms that are related to progesterone secretion. Remember, progesterone secretion only occurs from ovulatory cycles. These symptoms are called menstrual melamina and include premenstrual breast tenderness and bloating from progesterone-mediated slowing of GI peristalsis. Prostaglandins are only produced from an ovulatory endometrium. The presence of menstrual cramps is another sign that ovulation has occurred 14 days earlier. Finally, progesterone secretion is associated with a basal temperature increase that exists for the 2 weeks of the luteal phase or the first trimester of an ensuing pregnancy. The taking of one's body temperature immediately upon awakening, called the basal body temperature, can identify that ovulation has occurred. The basal temperature may rise as much as 1 degree Fahrenheit the day after ovulation. Below are listed a number of take-home points that you should take a few moments to briefly read and will summarize what we have just reviewed.